Well, this is a very historic moment, a moment we've been waiting for many of us for several years, I suppose. And it's a delight to introduce Sonny Dhanani, who really needs no introduction to most of us here. He is a giant in the area nationally, internationally in organ donation research. He's an associate professor in Ottawa. He's a pediatric intensivist at CHIO. We know that. He was recently a medical officer of donation at Trillium Gift of Life Network. He's the chair of the new Canadian Donation Physician Network. He's the chair of the Canadian Blood Services National Deceased Donation Advisory Committee. And he's the associate director for donation research at the CIHR-funded Canadian Donation and Transplant Research Program. And as you know, his focus is leading international research pertaining to practices and standards for determining death after circulatory arrest for the purpose of organ donation. So, Sonny, thanks a lot. We're really looking forward to this.
Thank you so much for that warm introduction. Thank you so much for coming during your lunch hour. I have 20 minutes to tell you about the DPART study. One, I'd like to start with a few thanks, of course, to Sam Shemy, who's photograph there looks like he's scrutinizing everything I do, but I'd call it mentorship. I'd also like to thank Laura, Amanda, Melanie, and Nathan, our core team, who helped, and without them could not run this study. And in fact, probably the talk would end with this slide, and it would be an awkward 20 minutes. The trials group and the CDTRP, key organizations supporting this project as well. It is Remembrance Day, but I'd also like to take a minute to remember the individuals participating in this study and the families that consented at their times of grief. It's really important to recognize that these aren't just numbers and graphs, that these are individuals and their families that are supplying this data, and we're very grateful. Disclosures right now, I have a stipend from Trillium Gift of Life for a hospital donation physician. I think most people in this room now know the term DCD and donation after circulatory death. Standards of practice in Canada have been there since 2006, and donation by DCD has increased significantly in Canada internationally. Now, this hadn't come without controversy, and that controversy still exists. Many areas, but one of the focuses that we had was this question of the declaration of circulatory death. Now, this was a media outlet, but we had academic discussions, even here in this room. The fundamental principle that surrounded this was the dead donor rule, where one must be dead before donation. And so we need to be comfortable, as we were in brain death, generally, about circulatory death as well, because we knew donation practice, and going forward, helping families donate, helping transplanters receive organs, that we needed trust. In Canada, we started with a 5-minute hands-off period to ensure death had occurred by circulatory criteria, and if we didn't wait, we risked violating the dead donor rule if we weren't sure they were dead, and if we waited too long, the risk of deteriorating organs. And the fundamental problem surrounding the determination of death was really this concept of autoresuscitation, the resumption of spontaneous circulation after declaration of death. Now, we know that there are many, many case reports, and in fact, many of you in the crowd had put up your hand when I asked you, had you witnessed or participated in an event like this? But does it actually exist? And how are we finding out? So with the help of many people, we put together the Death Prediction and Physiology After Removal of Therapy study, the DPART study. And our main objective was to identify objectively, prospectively, the incidence of autoresuscitation as reported by the healthcare team. This was in critically ill patients who were dying in the ICU following withdrawal. Our secondary outcome, among many, was to actually identify the incidence, not by clinical reports, but by waveform. So I'd like to go through our preliminary findings today. So it was a prospective design, it was observational, in only ICU patients, only those who had consented to withdrawal. We started with 13 sites and moved to 20 sites, not just in Canada, the Czech Republic and the Netherlands, both countries having high DCD rates. Our inclusion criteria were all patients, but they had to have the monitoring involved, an ECG, a saturation, and a blood pressure, an arterial blood pressure. I don't want you to get afraid of this slide, but this is our timeline. I want to highlight the amount of data we collected from the decision to withdraw, decisions for DCD, consent to the study, it was active, full consent, to the timing around withdrawal, what happened, did they extubate, what drugs were used, we collected all that, as well as what happened during death and after the declaration of death, how they did it, what tests were used. But for this purpose, I want to focus on one, the clinical reports of autoresuscitation, the resumption of circulation, and the monitors and waveforms that we started at least 15 minutes prior to withdrawal to at least 30 minutes after withdrawal. We had 647 patients enrolled, and that was with a 93% consent rates, which is much higher than most ICU consent rates. And that's thanks to the team, our protocols, and our collaborators at the bedside, and of course, the families. We had protocol violations that brought us down to 631, and that's important because that was our first N. That was the N that we calculated how many had clinical autoresuscitation. Unfortunately, not all of them maintained their waveforms and monitors, so we lost a few patients, and our second N is 480 patients, where we're able to monitor all those waveforms and review them. I'll get back to that. So our first outcome was clinical autoresuscitation. I'd like to tell you that all the patients died, so neuroprognostication was good in this group, and that there were 13 reports out of the 631. Most of them were by nurses, some of them by the physicians, and some of them both. Interestingly, one had a research coordinator that identified it. What did they tell us? How did they identify it? 4 out of the 13 told us that there was electrical and blood pressure activity, and one said return of good waveforms. We assumed that was the same. 2 people said that there was respiratory activity that resumed, and the rest of them said there was just electrical activity that resumed. But were these really cases of unassisted resumption? Or were there monitoring issues? Were there reporting issues? Were they at the bedside the whole time? Our colleague Nathan Scales created a waveform viewer and a beep browser. This beep browser could identify all cessations of circulation, the pauses, and any resumptions. But before we used the beep browser, we needed to tell it what to do. So we needed to define what cessation by waveform was before we could identify what resumption was. We created a waveform adjudication expert panel. We brought together an adjudication working group, and of course, we had our very knowledgeable DPART steering committee. There were a lot of people that looked at these questions and really designated as experts in clinical and physiologic understanding of return of circulation. Not just, or actually chosen, that they weren't just donation specialists. And we wanted them to define cessation of circulation by waveform and subsequently resumption. What did they find? What did they tell us to do? Well, they defined cessation of circulation as not a systolic pressure, but a decrease in pulse pressure to less than 5 millimeters of mercury that lasted for at least 60 seconds. From there, the corollary would be that an unassisted resumption of spontaneous circulation by waveform would mean at least 1 beat with a pulse pressure of at least 5 millimeters of mercury that lasted at least 60 seconds. Now, as we started reviewing the waveforms, we recognized that there were true patterns of transient cessation of circulation that those criteria helped us define. The first one you may have seen. The top line is the blood pressure. The second green one is electrical activity. This is what you see at the bedside. You can see the scale is from 20 to 140. Let me zoom it in for you, because we could do that now, because we had the waveform viewer and the beep browser. You can clearly see that we found a pause for 60 seconds. That fit the criteria. And in fact, the resumption was higher than 5 millimeters mercury. And so this is one of the ones that we would have defined as a cessation of circulation and a resumption of circulation. Now, this graph looks very similar, a little different when I zoom in. You can see that at the bedside, you wouldn't have noticed, but we had the objective eye to be able to analyze this. The adjudication committee recognized this and tried to find evidence, their own experience, their colleagues, to identify what was meaningful. And that's where we got the 5 millimeters of mercury. So you can see this is what was at the bedside, and this is what we were able to see. So using that definition, now I must say that most transient cessations were in this category. It's an absolute decrease in both blood pressure and electrical activity. So we had the beep browser, we had definitions, but in fact, because this was such a sensitive topic, we brought together adjudicators. We had a complex algorithm to make sure that each waveform was reviewed by at least 2 adjudicators. If there was a cessation and a resumption, it was a further 2. If there was any disagreement, there was another adjudicator. So there was a lot of work here. And we fed them. You can see Matt has an Apple Core. So what did we find? Let me go back to those 13 reports. Well, the first 2 actually lost signal, and so we couldn't prove or disprove whether those were true, verified autoresuscitations. 6 out of the 13 only had electrical activity resume, not blood pressure, or if it had blood pressure, stop and start. It was less than 60 seconds, around 30 seconds, so didn't fit our definition. And 5 of those reports, so 5 of the 631, validated with waveform. So that was our first finding. Let me give you an example. I'm assuming this is going to work. The top is blood pressure, the bottom is electrical activity. You can see the entire graph on the right. We've now lost blood pressure and lost electrical activity. And if you wait just a second, you should see a little spike. Now you can imagine at the bedside, if they had their own criteria, they may have called this autoresuscitation just by electrical activity. So we were able to review these, and that's why our definitions were so important a priori before going forward. This is one that verified a clinical report to a waveform report. So you have blood pressure with a mean of about 40. We have some electrical spikes and a resumption after 2 minutes and 56 seconds with a mean pulse pressure of 42 before absolute cessation. So those are the 13 patients. We found 5 true waveform verified resumptions of circulation. But what about all the waveforms we had? These included those 13, but we went and looked at the 480 patients that we had robust waveform data. Remember our definitions? Out of those 480, we found 69 patients that identified as cessations, transient cessations with a resumption after 1 minute greater than 5 millimeters of pulse pressure. There were 81 events, in fact, in 69 patients. I put this as a general slide. There's still further analysis. I've broken it up into 2 categories. The dark blue is the clinical autoresuscitations and the 5 verified. Hard to make further discussion about that. But when we look at the waveform in the light blue, 480, and the 69 resumptions patients in there, we can get a general idea that there was no difference in those. So we didn't identify, or haven't identified yet, patients that were more likely to have resuscitation. What was our longest transient resuscitation before there was a resumption? And I think this is really the money slide. It was 4 minutes and 20 seconds. To clarify, that included the 1 minute that we used as our definition, then 3 minutes and 20 seconds after that, where there was a cessation, absence of pulsatile activity. I'm not commenting on electrical ECG activity. and then that beat greater than 5 millimeters of mercury. You would then ask, well, what was the distribution? If the longest one was 4 minutes and 20 seconds, was there anything over 5 minutes? No. What was most common was somewhere between 1 and 2 minutes. Keeping in mind, the first minute was our definition of cessation. So very early and very short. How long? Let me give you an example of the 4 minute, because I think that's really interesting. There was actually 2 cessations here. Got a few minutes more. You can see electrical activity continuing. And this is where it might feel uncomfortable, because I'm going to say, wait for it, wait for it, wait for it. This is sped up. You can imagine that it's really important to make sure, especially in a DCD case, that you don't miss that blip. There were subsequent more after 1 minute and 56 before absolute cessation. How long did the typical resuscitation last? Most of them were just 1 beat, in that 0 to 5 second range. Very few lasted longer than that. The longest one was 13 minutes and 14 seconds. In fact, this is a very interesting case because it had 4 separate cessations of 1 minute and resumptions over 1 minute. I won't go through this one. The other thing that we found when we looked at the number of case reports of autoresuscitation that are out there in the public versus what we were finding is that there were a lot of things that mimicked autoresuscitation. We talked about how electrical activity, if you had different definitions, might be considered autoresuscitation. But we also found a problem with scaling. Now, this takes a minute to run through, so I'll comment on part of our criteria was to include oxygen saturation plus in all our patients. But in fact, we got rid of that criteria because they weren't reliable. They often lost signal well before the last beat. This one has end-tidal CO2, and you can see automatically right there, we lost, I think it doesn't go through. We start losing circulation here. But in fact, you can see on the right, it's actually because of scaling. Now, if you looked away, you probably wouldn't have recognized that one event as being scaling and would have just seen it return. So again, constant monitoring is super important. Now, this one goes by pretty quickly. Another concern we had was the impact of ventilation on arterial blood pressure. Now, you can see the arterial blood pressure waveform decreasing, but you see this consistent pulsatile pressure correlating with the respiratory activity and the CO2. Clearly, there was a ventilator going on here. Now, in some centers, they keep the ventilator on during withdrawal. So you can see the impact of how we withdraw, the impact of what we're monitoring, and this new information impacts the reporting of autoresuscitation. So what do we do with this information in the last 2 minutes? We know that when we surveyed physicians, a lot of people, 37%, had identified seeing it themselves, that they believe it's important. They believe it's important, especially in the context of organ donation. And so there's a lot of variability in how long we should wait. In Canada, we picked 5 minutes, but some places have gone down to 2. For a long time, people waited to 10 minutes. There are a lot of reports, longer than what I'm telling you at 4 minutes and 20 seconds, up to 10 minutes. What about all those? Well, in fact, those are what we call Lazarus phenomena rather than autoresuscitation. It's the reporting of resumption in the context of CPR. And there are dozens of cases, longest up to 10 minutes, some reports up to 20. So that's not what we're talking about, but we're talking about autoresuscitation after withdrawal. And in fact, there are very few case reports. Our study is the largest to document this. And in fact, in those previous ones, the longest reported with intact monitoring was only 1 minute and 42 seconds. So from there, what are our preliminary results? Transient, unassisted return of circulation or autoresuscitation does occur after withdrawal of life-sustaining therapy. Some people believed it. Now everyone should know it. That clinically, we saw 5 out of 631 that correlated with actual waveform, unassisted return of circulation. But I think more importantly, the monitored data out of 480, we found 69 patients, 81 events of this happening. Most are transient, and most are just between 1 and 2 minutes long, almost all of them, but the longest was 4 minutes and 20 seconds. And a reminder that all these patients died. Where can we take this information? It's preliminary, so the interpretation, I think, still is loose. But right now, I'm thankful that our current standard in Canada of having 5 minutes hands-off period with constant monitoring is appropriate and safe. I think arterial blood pressure monitoring in all DCD cases specifically is important, and a decision on all death is up to you. That we have to make sure that we understand our monitors because scaling can be an issue, and we should make some better definitions on whether to include ECG or not. And when unassisted return of circulation occurs, because it does, then restart the clock in DCD, as resumptions are transient and these people can still be donors. So I'd like to thank the coordinators. Without them, this would not have gone forward. A huge group of co-investors and collaborators, many of them are in the room, and I'd like to thank you. The CDTRP and the trials group specifically for their support in getting us started and keeping us going, especially when times were tough. Again, the individuals and their families, my patient and family partners that are here in the room, and our core DPAR team. I'd like to thank you for your time and attention.
I want to introduce our commentary speaker, Don Griesdale from the University of British Columbia in Vancouver. Thank you.
There we go, success. Hi, good afternoon. My name is Don from Vancouver. Thanks to the organizers and thanks very much for having me here. It's really, truly an honor to be able to present and maybe give my two takes on this really important study. I have no conflicts to declare. Now, interesting, death is a process. The study reinforced that for me. And uncertainty in the timing of death is not new. And in fact, probably that lack of trust that people have in their physicians in determining death has led to the development of lots of ways to circumvent that. So if you die and this is you in your coffin, you can signal people that you're in fact probably buried prematurely. And I think that defining death, therefore, underpins that trusting relationship that we have with our patients. It's particularly so as it relates to donation. Now, I, like Sonny, feel very fortunate that we have the 5-minute no-touch time here in Canada, developed by people up here like Sam Shemy and Andrew Baker. But we have to acknowledge that there's variability throughout the world, and the ATS and the Society of Critical Care Medicine uses a 2-minute guideline. The literature before this study was generally small, single center. Here's one study that looked at 73 patients that were undergoing a 5-minute withdrawal of life-sustaining therapy with a 5-minute window for DCD. And they concluded that in those 73 patients, they saw no episodes of autoresuscitation in 2 minutes, and therefore concluded that the 2-minute observation period is sufficient. So where does DEPART leave us then? Well, clearly, huge study, 630 patients across 20 ICUs in 3 countries. So the generalizability is incredible. They had both standardized timelines, leaving the monitoring on for 30 minutes, so truly we're able to capture these events when they occurred, and standardized definitions, which I think had been lacking up until this point. Wavelet, detailed physiologic monitoring beat by beat for 480 patients, really unheard of. And so where Sonny said, wow, we missed a few patients, man, I cannot believe I've done some physiologic work, and getting that amount of data capture and that granularity of data is truly an accomplishment. And importantly, they saw enough patients that had at least one episode of return of circulation. And so that they're, I think, adequately powered. There's enough events. The event rate is high enough that they could actually see that. I think reassured for me is that the majority occurred within 2 minutes, and the majority were less than 5 seconds in duration. So if I had 3 points to make, the first I would say that these are incredibly impactful results. Once again, it reinforces to me death is not a point in time, but it's a process. I'm reassured that all patients did pass away from this. And really importantly, that no patients who met the 5-minute criteria had had one episode of an unassisted resumption of circulation. So I think it reassures us that the foresight that Sam Shemy and Andrew Baker and the people that develop our Canadian guidelines, that these fit within those guidelines. The other thing that I was rest assured by, that of the 68 patients who were DCD donors, 2 patients had return of circulation and both were recognized and the clock was restarted. So the way that we've set up, the way that we practice appears to work. And I think Sonny's take-home points are absolutely bang on, that the 5-minute rule is appropriate. For the DCD, an arterial line is absolutely imperative. And if we get a return to spontaneous circulation, restart the clock. I don't want to minimize, because when I first got I love doing this because I get the first-hand knowledge of all of this, right, as an outsider. And I was blown away that 93% of patients consented. I remember when Sonny first presented this program to the trials group years back, we said, I don't know if you can actually do this. Like consenting during the dying process. And for me, it really speaks to the professional and multidisciplinary team of clinicians, like bedside clinicians, physicians and nurses, researchers, ethicists, administrators, policymakers, and most importantly, patient family partners that were engaged and respectful throughout the process, and really an absolute testament to achieving this, Sonny. Like, that's incredible. And I think the most important bit with all of this is true patient engagement and inform the research process throughout. So, and I don't want to miss, I know, I believe Heather Talbot's in the crowd. There may be other patient partners. Thank you for sharing your story. Thank you for participating in this important research that really guides policy. And really, we're really beholden to you and the other patient partners as part of this. I think it's really the standard by which we need to be doing integrated research moving forward. And then I think the final point, just to maybe take a bit of a step back, is that for me, it really tries to start addressing more important, maybe not more important, but future questions. And I know this is a very small study, but Sonny and the research group, the TPAR group, have reached out to saying, well, listen, what other things should we be looking at? Are there other definitions of death? And I don't want to get into the dead donor rule and the pros and cons with that, but what happens to the neurologic function at the time of death? And looking at EEG, and I know Merit Saslav is leading an endeavor at London to try to look at really integrated neurophysiologic monitoring at the time of death. And I think that's really important. And because of that, I know Sam Shemy and Sonny and Andrew Baker are really trying to, what is death? It probably isn't just an organ-based definition when your heart stops or brain death, but maybe take a look at a more cohesive assessment of what is death. And I think this research is going to fundamentally help to inform that as we come up with perhaps more appropriate definitions moving forward. So in the end, my conclusions, I think honestly, large, very well-conducted, multi-center study of the dying process in intensive care unit. The results are incredibly clinically meaningful. The recommendations are sound. And I think, importantly, it's a broader research program that's going to inform practice and policy for our bedside care providers, administrators, policymakers, and importantly, patients and families. And I think it opens up the conversation to addressing some of the fundamental questions in the dying process. So with that, I'll stop. I want to really turn it over to the real important questions for Sonny, and thank you for your time.